welcome everyone to our webinar today. We are very excited with this expert panel. We're going to talk to you about our frequently asked questions. Questions we get all the time from clinicians, new users of the breather, somebody that's been recommended to us, and we want to answer those questions for you. And we have picked the cream of the crop, the best experts to answer those. So let's meet our expert panel first. First up, we have Dr. Sigfredo Aldarondo. Dr. Aldarondo has been practicing pulmonary medicine for the last 35 years. He also served our country as Lieutenant Colonel in the U.S. Army Reserves Medical Corps. He is recognized as one of the top physicians in his field and an associate professor at the University of Central Florida's School of Medicine. He's the medical director of pulmonary rehab for Advent Health, and he serves as chief medical director for PN Medical. Welcome, Dr. Aldarondo.
Thank you, Wendy. Glad to be here.
Great. Next up, we have Dr. Nina Balsic. Dr. Balsic has been a research scientist for over 12 years. She developed her scientific and leadership skills during research and teaching at the University of Oxford and the University of Sheffield in the UK. She excels as a biologist and geneticist and has been granted funding in cancer research in the UK. Her findings have been published in the international journals. She works in the areas of fertility, immunology, and oncology as a researcher. She serves as chief scientist for PN Medical, where she continues her research investigating the effectiveness of RMT. She is also a research collaborator for the Mayo Clinic. Welcome, Nina.
Welcome. Hi, Wendy.
Next up, we have Brenda Parkhurst. Brenda has been a nurse for 30 plus years. She has extensive clinical knowledge and experience in acute care, hospitals, skilled nursing facilities, assisted living, private practice, home health, and hospice settings. Brenda has a passion for sharing her knowledge and skills with other healthcare professionals, looking to enhance their scope of practice or to assist others in taking that next step within their professional career. Brenda serves as our nursing content expert for PN Medical. Welcome, Brenda.
Thank you, Wendy. It's great to join everybody.
Next up is our master clinician, Betsy Page. Betsy has been a medical-based SLP for over 15 years. She's worked in skilled nursing, outpatient, and home health, serving those with various and often multiple medical conditions. She is passionate about working toward functional outcomes to improve her clients' quality of life, as well as serving in clinical program development, education, and implementation. Betsy serves as PN Medical's master clinician and uses her knowledge and experience to train others looking for ways to implement respiratory muscle training in their own practice. Thanks for being here, Betsy.
Thanks for having me.
Next on our panel, we have Christy Tagey. Christy has been an occupational therapist for 26 years. She serves as Chief Operations Officer for PN Medical and our OT content expert. Christy has been a clinical specialist as well as operations, working in various healthcare settings. She is excited to use her expertise in order to give back to the profession that has brought her so much joy. Thanks for being here, Christy.
Thanks, Wendy.
And last but certainly not least is Dr. Tom Berlin. Dr. Berlin has been a respiratory therapist for over 35 years, with 19 years as an adjunct professor. He currently leads and educates colleagues in order to improve their respiratory therapy skills and outcomes. He serves as respiratory therapist or RT content expert for PN Medical. Welcome.
My pleasure.
Our first question for each panelist will be related to the scope of practice. We have viewers from all disciplines, and it's important to know how respiratory muscle training or RMT relates to each of our disciplines. And sometimes we have new users that want to know which discipline to kind of go to for advice with using RMT. So Dr. Aldarondo, I'll start with you. How does RMT fit into the scope of practice for a physician or a physician extender?
Well, respiratory muscle training is a strategy that is implemented once there is an appreciation that there is respiratory muscle dysfunction or respiratory muscle weakness present. And that requires a degree of clinical acumen from the clinician to recognize that that's likely present. But it's also properly handled or tackled when you measure it, when you actually can have an objective idea that the respiratory muscle weakness is actually present. And you can actually do that and qualify and quantify that by measuring the maximum inspiratory pressure and maximum expiratory pressure, which can be done in the pulmonary functional lab, also known as MEP or PI max, PE max. Same, different abbreviations for the same thing. But the point is that it is something that we can measure, that we can, once we measure, we can identify it and isolate as a physiologic abnormality or a pathophysiologic respiratory issue that it's amenable to treatment. It's amenable to treatment by employing respiratory muscle training. Therefore, it is gratifying that we can not only measure this, but we actually have tools to address this dysfunction when present. And we can not only diagnose it initially and measure it, but it is amenable for serial testing, so we can actually gauge the evolution of the clinical problem and also the response to therapy.
So Dr. Berlin, it kind of speaks for itself, respiratory muscle training, respiratory therapist, but tell us how it impacts the scope of practice for an RT.
Well, respiratory therapists work with patients suffering from cardiopulmonary illness, cardiopulmonary morbidity. Respiratory muscle weaknesses exacerbate a host of issues that can prevent or impede a patient's optimal health. So RMT is a tool in the pulmonary rehabilitation toolbox that can be performed in almost any setting. So the breather was developed by an RT, and its use is certainly within the respiratory therapist scope, whether that's for some inpatient applications or as an outpatient.
Great. Now, I know from my own research and experience with physical therapy, I know that it's becoming more and more part of the scope of practice for physical therapy. It seems like it was a part of respiratory therapy, their chest PT, and PT was working with RMT in the past. And it seems like lately I hear more and more about it. We even had a PT that works in RMT daily as one of our guest speakers on one of our webinars. So I know that it plugs right into the scope of practice for PT. For OT, I don't see it as often, but I'm hearing more and more, and we're getting more questions from occupational therapists. So we know that it's within the scope of practice to help with functional capacity in order to do your ADLs and that endurance that you need. But Christy, can you share a little bit about how we wouldn't want to all be working on respiratory muscle training at the same time?
Sure. And I think you make a good point in having all of us here present with different backgrounds and different disciplines demonstrates that there is no one scope of practice that owns respiratory muscle training. When we all have an understanding of what respiratory muscle weakness is, we can better impact the patients who come before us. So I may have a patient that's referred to me that Dr. Berlin has never seen. So I need to have the skills to be able to identify, to assess, and intervene for those patients. So as you mentioned, physical therapists are beginning to more and more get involved in identifying and assessing and treating those patients, because they're working with patients on functional mobility. I've spoken with physical therapists who are working with patients who have had specifically phrenic nerve involvement, and they're specifically addressing that weakness. We also know that the diaphragm is the biggest muscle of respiration. And one of the other things that diaphragm, part of its job, is with postural control. So certainly that's something that physical therapists and occupational therapists are concerned about. Think about frequently when you get a patient referred to you, they're typically not in the best shape. They're deconditioned. And so oftentimes, before we can do a whole lot with a patient, we have to get them to a stronger place where they can tolerate the exercises that they need to do for their arms and their legs. Respiratory muscle training is no different in that it strengthens. But what it does is it allows the patient to have less dyspnea in most cases, and to be able to participate more in their PT or their OT or their speech, whatever that might be. So as an occupational therapist, I may be talking about activity tolerance, do more than just take a shower. Now they can take a shower and have coffee with their spouse, or maybe their goal is to be able to go to the hairdresser or go to church. We want to impact that. We know that respiratory muscle weakness can be one of the biggest negative impairments around quality of life. So if Brenda is in home health and she has a patient that's only referred to her because she's going to teach and train disease management for this patient, they've been hospitalized with COPD or whatever their diagnosis is, she, within her scope of practice, is able to identify, assess, and treat if she has been trained. So that's the goal, is that we want to be able to have the clinical tools to be able to identify, assess, and treat, whether we're OT, PT, speech, respiratory therapy, physician, or physician extender. So while we all might be trained in it, we definitely want one discipline to take the primary role, where they're going to assess respiratory muscle weakness. And certainly we have a conversation if there's an interdisciplinary team who's going to take that primary role, assess it, write the goals for it. But then the rest of us who might be in a supporting role can talk to the patient about how they're doing with their respiratory muscle strengthening. During ADLs, I can incorporate breather use in their routine so that it becomes a lifelong intervention, the lifelong routine that's going to help keep them out of the hospital, or hopefully have less impact if they do get sick.
And even if I'm not the one taking the lead, I can promote it every time I see the patient, because the more they hear it and the better they'll do. So great point.
Let me add, let's think about this scenario. Dr. Alderondo refers patient X to us, his home health team. Brenda goes in, does an assessment and sees aerobic capacity is impaired. Betsy goes in and assesses and notices there's a swallow dysfunction. I go in and I see activity tolerance is impacting ADLs. And physical therapy goes in and finds that endurance is impacting functional mobility. As an interdisciplinary team, we're going to talk amongst each other to see who's going to take the lead, and likely that's going to be decided by primary diagnosis. And then the rest of us will take a supporting role to talk to that patient about how they're doing. How are you feeling? What are your settings? How do you clean your breather? We want to be sure that they're getting the message from all of us that this is important and this is a lifelong habit to be adopted.
Great. And if you're lucky enough to work in a hospital setting, RT is going to automatically usually take that role, and we can all support that. So great points. Thank you. Now back to Brenda. Christy did call you out, Brenda. Tell us about nursing and RMT.
Well, we know that nursing, when we're seeing our patient for the first time, we always start with an assessment, and nurses do a head to toe assessment all the way from the head to the toe. And when we get down into the pulmonary, we're looking at a pulmonary respiratory really evaluation. What are the lung sounds? What is the anterior? What are the posterior lung sounds? Are we seeing shallow respirations? What kind of quality air exchange are we really hearing as we auscultate it? What is the pulse oximetry reading? Nursing scope of practice really evaluates pulmonary status and deficits, all the way down to the nurse aide, possibly in a home setting or in a facility or a hospital, as they're taking vital signs and listening and checking pulse ox. Nursing also does a lot of pulmonary treatments. I think back to the hospital setting, and I'm a little older, those incentive spirometers have been around a long time, and we all worked with those, but when we're talking about medication for pulmonary status, we've got oxygen. It is a medicine. We're administering it. We're seeing the effectiveness of it. Nebulizers, handhelds, multi-dose inhalers, all of those things really in the nursing scope of practice as we administer, we're supposed to really see the effects of them pre and post. Are they working? Nursing really teaches respiratory techniques to enhance that pulmonary exchange of oxygen. You know, so many times we'll watch someone go up the stairs, or we'll watch someone try to eat and talk, and they can't because they're short of breath.
Right.
Or they start panting when they go up the stairs, and we know that they're not using their full lungs. This is what we're talking about here as an interdisciplinary team. It could be just COPD. It could be that we're lazy and we just don't take deep breaths. I will raise my hand for that. So nursing has already been doing these pulmonary assessments like all the other disciplines as long as we've practiced. We just are wanting to recognize that we can help drive utilization of a better gas exchange and full air movement, not just with the lungs, but with those muscles within the diaphragm.
Great, thank you. Now, Betsy, you're going to be talking a lot today because many of our frequently asked questions, our FAQs, come from speech language pathologists. They send up a lot of questions. They're treating, a lot. So tell us a little bit about the scope, and then I know we have a lot more questions related to that later.
So as a speech therapist, the places that I'm looking at the respiratory support typically fall in two categories. One is for speech production. We know that respiration is one of the subsystems of motor speech, specifically the power for phonation. So if I identify a respiratory muscle weakness that's limiting the power necessity for the person's voicing needs, which could be various depending on what the person needs to do, RMT is a great thing to consider implementing for that. Another area is swallow function. Coordination of respiration and swallow is very important for airway protection. Also, a person needs a productive cough, and we need a strong respiratory muscle support for that. Endurance is another thing to look at. We need enough respiratory support so that we can continue that safe swallow respiration coordination to meet our nutrition and hydration needs. And then also to do it safely. Sometimes we see patients that look great for a quick bedside swallow eval, but as the meal progresses, it starts to fall apart because the endurance is lacking. There's a secondary area I'll mention here. And I emphasize that it's secondary. And this is the area of cognitive functioning. And this is something that falls both within speech therapist scope of practice and also OT. We know that the brain is sensitive to oxygenation, and we may notice improvements in cognition as overall efficiency of oxygenation improves in patients where the respiratory muscle weakness is identified. So to clarify, I have not used RMT to directly treat cognition,
Right.
and I would not expect it to improve cognition in a patient where oxygenation is already optimized. But it's worth noting that when a patient does have a compromise in oxygenation, we can look and see if there's a respiratory muscle weakness and oftentimes see an optimization there. It's worth noting because we don't want to mistake some symptoms of oxygenation inefficiency for maybe a chronic or progressive disease. We want to take a full picture of the patient because very often they have comorbidities. It's also worth noting that there's some exciting new and emerging research in this line of study, and you can find more information on that on the science blog page of the PAN Medical website.
And we are really, really lucky. And we have a scientist here with us today, but we also have Dr. Balsick to consult with all the time. And I think that really sets us apart. We have somebody to go to and say, have you found any research? Are you doing any research? It's really nice. So I'm going to put you on the spot next, Dr. Balsick. How can we relate all of this to your scope of practice, which is science?
Well, I mean, I'm the only non-clinician here, really. So I'm not looking at patients. I can't assess respiratory muscle weakness, and I can't tell anyone to do respiratory muscle training. But there is a lot of evidence about RMT out there. It's been around. Respiratory muscle training has been done systematically for 4 decades now, with medical devices such as the breather. And since then, there has been research accumulating for different diseases, different devices, different methods, different approaches. There are many papers that are comparing different aspects of respiratory muscle training and their effectiveness. And that's kind of where science is interested in. It is kind of, we want to know, what does respiratory muscle training do in a healthy person, in an athlete, in a patient, in different patient populations? How long do you have to do it? What is the best protocol? What are the outcomes that can be expected? What is the physiology behind respiratory muscle training? So this is where the science is really interested in the subject, and this is where I can maybe help answer questions that come up from anybody doing RMT or thinking about it.
Wonderful. I love how we started with this, because it really shows how each of us fit into the puzzle that is RMT, and we all have the same goal. We want these patients to get better and be better. So that's wonderful. I wanted to start our first FAQ after talking about the scope. I wanted to start with one that comes in the most often. How does the breather device, we're talking about RMT today, but how does the breather relate, compare, or maybe totally different than other devices? Because that is a valid question. If you're looking for something to help yourself or to help your clients, you're going to be looking at different devices. So I wanted to start with that. And Betsy, if you could tell us a little bit how the breather is compared to some of the other devices.
I think one that we often get questions about is the EMST 150 device. And so, yeah, there's some differentiation. Both are respiratory muscle training devices. The breather trains both inspiratory and expiratory muscle groups in the same breath cycle. So that's one differentiation. Also, the breather uses resistance training to improve muscle strength and/or endurance. EMST is an expiratory muscle strength trainer using a threshold approach. So both target improving muscle strength. The breather includes inhale and exhale without the need for an additional adapter. Another distinction is the resistance approach utilized in the breather applies the workload, in this case the resistance, to the entire breath cycle. So this means the workload is for the entire inhale and the entire exhale. This is a little different from a threshold, where the person has to overcome the threshold and then there is no workload. And an application for this might be if we're looking at breathing pattern disorders. Very often our patients, and honestly in the general population for adults, we see a lot of breathing pattern disorders. So I like that with the breather, I can target also trying to get to a healthy breathing pattern during respiratory muscle training.
Now, what about those questions we get about a PEP or an oscillating device?
Yeah, that's another good question. A PEP device, and it often has a flutter valve, that's the oscillating. It's designed to target airway clearance or pulmonary hygiene. It does have positive expository pressure, that's where the name PEP comes from, but it's not at a level significant to cause muscle strengthening. It's not designed for that purpose. So it's really in a different category. It's not trying to be a respiratory muscle trainer, but it's worth noting that the PEP of a breather device is a higher resistance because we are targeting muscle strengthening, but the airway clearance benefits are often also observed. So clinicians need to be aware, if you're utilizing the breather with a patient, they may need to stop and cough, and that's good because they've mobilized those secretions. Also, if you have someone who's maybe on a vent, they may need to be suctioned.
That means it's done its job. Great.
If that is very true, if I could just add,
Yes.
using the breather, particularly the expiratory muscle training component, absolutely works as a secretion clearance mechanism, as well as improving oxygenation for those patients that have the ability to improve as it expands some collapsed alveoli during that expiratory pressure maneuver. So this is something that we see frequently.
If I may add, Tom, I completely agree with your comments, but in our clinical practice, many patients who do our benefit from the oscillator or flutter device, but yet are still very weak and not completely recovering from acute illness, or maybe so compromised because they have severe airway obstruction and weakened diaphragms. They actually can do even better when they combine the respiratory muscle training and then followed by the oscillator device.
Yeah.
So you actually increase the ability of the patient to benefit from the oscillating device by preconditioning, if you will, or pre-treatment with the respiratory muscle trainer as well.
Yes, I agree. Two separate therapeutic goals that sometimes intertwine.
Yep.
Great. I think that is very helpful because those questions do come in a lot. We're going to switch gears a little bit and go to some of our FAQs that are diagnosis specific. And these are tough because each individual is different. How I respond to a diagnosis would be different than somebody else. But we'll try to touch on these a little bit and just kind of give an overall question answer to these frequently asked questions. So Dr. Alderondo, we'll start with sleep apnea. Does RMT factor in with sleep apnea?
Well, it does. So sleep apnea, as many other clinical conditions, follow a wide spectrum from the very mild, clinically not very recognizable, to the very, very severe, obvious degree. And there are different phenotypes, different reasons why it happens. And the common denominator is that there is a collapse of the upper airway due to decreased muscle tone during sleep. Therefore causing the dynamic obstruction of the upper airway. So studies have been done with evaluating the efficacy of respiratory muscle training with sleep apnea. And there is a mild improvement when you look at the severity of the sleep apnea, there has been significant, not a very significant degree, but a mild degree of improvement when you look at the obstructive events. However, the respiratory quality of the quality of sleep is improved, and that's a very consistent finding. So when you look at that, along with that, obviously, respiratory muscle strength is increased. So you're looking at diverse reasons, diverse degrees of airway obstruction or airway dynamics that are affected during sleep, from what we call upper airway resistance without apnea to the full-blown apnea process. And we know that these are associated with arousals. So you can actually benefit the patient without making a definite impact on the sleep apnea itself, but you're looking at airway obstruction that is of a subclinical or diverse types that may be influenced by improving the muscle tone of the upper airways. So the answer to your question, Wendy, is that yes, it is potentially beneficial, particularly in those who have mild to moderate, not the extreme cases of sleep apnea.
Very good to know, because that question does come in. Another one that comes in recently, I've seen this, people will ask, hey, I have high blood pressure. And Brenda, would RMT be something that they would stay away from, or would it be something they could utilize with having the high blood pressure?
The breather will not create problems if you have high blood pressure. Your heart and lungs are one system that work together as one unit. The better your lungs work, it allows better oxygen for your heart to pump throughout your whole body. So the breather can enhance your cardiac status by allowing your blood vessels to relax and lower the actual blood pressure. So the heart and lungs medically is one system. And if you're helping your blood pressure and enhancing the oxygenation that flows throughout your body by taking therapeutic full breaths, utilizing your muscles in your diaphragm, it would only enhance and assist this process of getting oxygen throughout the body.
And Dr. Alderondo, what would you add to that?
Well, what I would say is that hypertension is incredibly prevalent or extremely common, that there is many reasons why it happens, and that the more fit, the more cardiovascular fitness is in play by regular exercise, by even doing core muscle exercises. We do respiratory muscle training, by improving the efficiency of ventilation, by improving the airflow during sleep and so forth, which is associated with paradoxic hypertension during sleep. All those things are in play, and therefore anything you can do to maximize, optimize those things is important, and in that includes respiratory muscle training. Of course, to what degree depends a bit on your body habitus, on what your other cardiovascular issues may be, but across the board, particularly those that are cardiovascular challenged, particularly those patients who have already cardiac dysfunction, patients who have valvular heart disease. We know that there is an increased prevalence of sleep disorder breathing when you have heart disease as well. So by optimizing upper airway muscle efficiency and strength, you actually can benefit and actually modify vascular tone, and hypertension may be benefited. Yeah.
Can I just add to that? That was really interesting what you just said, Dr. Alderondo. It was actually the first study that looked at the role of RMT in sleep apnea, that also found that besides the benefits of improving the sleep apnea, improving the quality and the quantity of sleep, it also reduced the blood pressure in that subject population. And they later showed that you don't have to have a massively high blood pressure to get this benefit. You know, even normotensive people do get a slight reduction in the blood pressure by RMT.
Yes, thank you.
We're going to stay a little more on these diagnoses. So Dr. Alderondo, I'm going to go back to you with, you touched a little bit about the heart. So heart failure, CHF, we get those questions that come in, whether they should stay away from RMT, but just elaborate a little more with that one.
Well, on the contrary, we know that by improving respiratory muscle strength, we actually may paradoxically improve or concomitantly improve cardiac output. So as a general group of individuals with congestive heart failure are more likely, just because they have congestive heart failure, are more likely to benefit from respiratory muscle training. So the presence of heart failure is not a contraindication, but on the contrary, is potentially an indication, particularly if you demonstrate that there is respiratory muscle weakness, and you can easily demonstrate that in the lab. So absolutely. Nina, you want to add to that?
No, I agree. This is what the research has shown. The research on chronic heart failure, congestive heart failure is quite extensive. The interesting thing here is that there seems to be more benefit if you use more of an endurance protocol, you know, rather than the normal high intensity protocol that we recommend of doing a few sets a few times a day at, you know, almost as high as you can go. Here we would recommend a more of an endurance protocol. You train it kind of at a lower intensity and then increase the duration or the frequency. And this has really been shown to give the best benefit. And there was a study that came out of an Austrian lab, actually. They showed that by doing respiratory muscle training, you actually change the autonomic modulation of the heart. So you actually improve the underlying pathophysiology of the heart failure, which I think was a great study.
Very exciting. Wow. Now we get the COPD, the emphysema, the asthma. We do get those frequently. You know, if RMT with the breather would help.
So the common denominator to those entities you mentioned, COPD, asthma, bronchiectasis, and also cystic fibrosis, for example, The common denominator is airflow obstruction. So all these patients have a reduction in airflow that's predominantly noticed or measurable or on exhalation. So they develop a secondary structural changes in their geometric changes in the thoracic cage. The diaphragm becomes less and less functional. The thoracic cavity is hyperinflated. And not as much with asthma unless you're dealing with severe asthma. So to qualify, we're not saying that respiratory muscle training for a mild asthma individual with mild intermittent asthma is going to make a big difference. It will make a significant difference if you have severe established, as we see in adults, persistent asthma of a severe degree. And there is a lot of overlap between those patients and those who have COPD, as we know it, emphysema, chronic bronchitis. The patients with cystic fibrosis are the epitome of the combination of obstructive problem with now a very severely diseased lining of the airways. The epithelium is very abnormal. They have very thick, abundant mucus that is characteristic for these patients. So they have airway blockage because of mucus plugging, literally. So whether you have cystic fibrosis or you have a persistent severe asthma, which results in airway secretions that are accumulating, or chronic bronchitis, you need, as part of your clinical benefit, you need to have a strong cough. You need to have an efficient cough mechanism, and that requires strong respiratory muscles. So one thing that we know that it's beneficial to our patients with obstructive lung disease or whatever nature is to have a strong respiratory muscle apparatus that will sustain and maintain adequate bronchial hygiene. And that's one thing that respiratory muscle training will do. And that's why we incorporate, one of the reasons why we incorporate respiratory muscle training as part of our overarching pulmonary rehab program. We basically define or refer to as peripheral muscles, which are the limbs, upper and lower extremities, and your central muscles, which is your diaphragm, respiratory muscles, expiratory muscles, and muscles that participate in the truncal strength and leads to gait improvement and balance and so forth. So got off the tangent a little bit, but basically in those diseases that are that you mentioned, for the reasons I mentioned, respiratory weakness having to do with an improvement in ventilation, but improvement in bronchial hygiene, improvement in cough and airway clearance is a very, very nice, important tool. So yes.
And I think it's good that you went in depth with that, because we get so many questions related. And I think these answers are really going to help put people's mind at ease and just give them a little security in what they choose to do next with their treatment. So I think that's very helpful.
If I could just add,
yes, please.
Dr. Aldarondo's comments, he's absolutely right. But as we mentioned before, the expiratory pressure component of expiratory muscle training helps splint the smaller airways to alleviate the gas that's being trapped in the lungs in patients with chronic illness or asthma exacerbation, chronic obstructive pulmonary disease. So in that effect, it's therapeutic from a different angle.
Sure,
good point. Thank you.
Dr. Balsick, you've mentioned some of the studies, and we love when you throw in your science with us. Do you have anything extra related to some of the diagnoses I said?
Probably lots of it. There is the science behind COPD and heart failure is probably the most established one with respiratory muscle training that has really been studied in detail. Also, what Dr. Aldarondo mentioned, the hyperinflation, how it works there, as well as the benefits that Dr. Berlin just mentioned of having expiratory muscle training, where you open up the airways, you improve the cough effectiveness. Also, there is a lot of evidence that has recently come using the breather directly. There have been quite a few studies that were published recently there. Was a nice study showing its effectiveness in COPD patients, and that was using the breather for 2 weeks only. Another study that has was our most recent one was in patients with dysphagia. So really looking at people who had impaired swallowing following a stroke, really. And what was shown there, that using the breather for 4 weeks improved swallowing performance, reduced the aspiration so that you're getting food stuck into your lungs, and improved the tolerance for a wider range of food and liquid consistencies. And all of this kind of really contributed to an improved quality of life. This is something that we see across all studies, that really if you improve the respiratory muscle weakness, you massively improve the quality of life. So for most of these diseases, there's ample evidence, and it is increasing. So if you want to look at a collection of the literature behind it, the PN Medical website is actually a really good place to go and look at. We have a science blog there that's connected to the Breathing University that you find there. And we really try to kind of collect some key papers there, explain them in really short articles, and then give you the link to the full text article, and list all the evidence there is for the breather, but also for other respiratory muscle training devices.
Now we're going to switch gears and go into mechanical ventilation. I think a lot of people want to know more about that. They're hearing it more in the news these days, and they want to understand if you would do RMT with mechanical ventilation. And Dr. Berlin, I'm going to send it to you.
Well, the question is, it depends. The answer is actually, it depends. So if your patient is in the acute phase of an illness requiring mechanical ventilation for respiratory failure, we would not normally apply respiratory muscle training in that situation. If the patient is being ventilated via an endotracheal tube, for example, which typically signifies that an acute phase of respiratory failure, we tend to shy away from the use of RMT at that point until we can get them over that acute phase of illness. If your patient progresses into more of a chronic dependency for mechanical ventilation, and particularly after tracheostomy, and tracheostomy often occurs now 7, 10, 14 days after being initially intubated for respiratory failure. And the patient is stable and is not on a high level of mechanical support, then you can start thinking about, okay, this patient has been lying around in an ICU bed, or even in a subacute facility bed, and is becoming quite debilitated. You would want to think of reconditioning these muscles of respiration, just like you would with the other skeletal muscles. So in that case, if your patient is stable enough to be off the mechanical ventilator for a period of time, supported by supplemental oxygen, to do a couple of sets of RMT a few times a day, then by all means, I think we should approach that, and we do fairly frequently.
Thank you. Now, many times as a clinician myself, I want to collaborate with all of you. I want to collaborate with the team. I want to do what's right. But all of us, whether you're the scientist or the clinician, we all want to collaborate with the nursing and the physician team. So the question we get a lot is if we need that physician's order in order to use the breather in our plan of care. Tom, what do you think?
Well, I think in the institutional environment, particularly the inpatient hospital, absolutely. Most of what we do in the hospital are chargeable procedures. So obviously everything needs to be driven by a licensed provider, the patient's physician, or an advanced practice provider. And so the groundwork for these orders for RMT has to be put in place in the context of the entire therapeutic objectives for that patient. Now, once the patient is outside of that environment, then it would be up to the individual physician. Anyone else, Christy?
Yeah, thank you, Tom. So frequently people are looking to get a breather, and they reach out to us and say, do I need an order to get a breather? The answer is no. You don't have to have an order from your physician to make a purchase of the breather. The breather is available on our website at pnmedical.com. Someone can reach out to us via email, can email us at sales@pnmedical.com, or they can pick up the phone and call us at area code 407-888-4242. 2795 and can purchase the breather as a consumer. In other settings, that really is up to that individual setting. Some home health care agencies do put it on the 485 for the physician to sign off on. But the breather itself is a strengthening tool, like a cuff weight, like a hand weight, used in strengthening the peripheral muscles, the arms, the legs. So we definitely want to have our interventions included in the plan of care where that's appropriate. But in terms of individuals who just want to purchase the breather and have it for themselves or for a family, you can order the breather in the ways that I just mentioned without an order from a physician.
Yeah, that's a good point. PN Medical also provides the breather fit for athletic conditioning, which obviously would not require a provider's order for that.
Absolutely.
And can I just mention here, as a consumer, as a patient at home, you can order and it's no problem. And we do provide a full set of training videos. So you don't just purchase it and you get sent home with it. On the PN Medical website, we take you through all the steps on how to use the breather, what's the best protocol, how to clean it. You can download a training journal. So we help you through all your breather experience.
Yes, thank you, Nina. And when you do purchase a breather, on the insert with the breather are those steps, how to find that, what Nina was just talking about, that start page that takes you from what do I do once I get it through how do I clean it? How do I know how to use that? So those are available, and you can even look at it without having purchased one by going to our website, pnmedical.com, and clicking on the start button.
Now, Brenda, nurses work very closely with the physician, so sometimes the patients or the clients will come to the nurse and ask, can I stop taking my medication now that they're doing RMT with me? What would you say to them?
No, we don't ever stop taking medicine until the physician tells us we can. The breather will not replace your medicine. Studies have revealed that respiratory muscle training strengthens your pulmonary respiratory abilities, and it will actually enhance that pulmonary medicine distribution and absorption within your lungs. You know, the beneficial effects of respiratory muscle training on your expiratory exhale muscles also reduces the issues of residual drug buildup in the lungs. So, which would improve the drug purpose and the way it works. So definitely we never stop medication until the physician orders it. But yes, the breather can enhance the utilization of the medicine for your lungs.
Now we're going to go back to what Nina brought up earlier with the dysphagia, however you want to say it. Betsy, tell us about RMT and dysphagia for someone with swallowing issues.
Yeah. So absolutely, there are some cases where you will want to use RMT, but it is going to depend on the presentation of the dysphagia. Particularly, we'll look at it when there's a concern for airway compromise. And what we're going to do is look for a respiratory muscle weakness. In addition to anecdotal feedback from clients and then outcomes that clinicians have seen in treatment, there's good indication that the breather would be expected to improve swallowing. So we're looking at improving muscles of both inspiration and expiration. And as I mentioned before, coordination of respiration and swallow is very important. Swallowing is very complex neuromuscular sequence, and it all needs to be on point so that we can eat and drink and keep our airways safe. So we need both strength for that to happen each and every swallow, and we need that for endurance to be able to provide the adequate nutrition and hydration with safety. Scientific evidence has also shown improvements in expiratory muscle strength correlating with improved swallow function in patients. And we note that there's hyolaryngeal activation with RMT, which is a great bonus in conjunction with my other direct treatment modalities. One of the things I love about the breather is it's pretty quick. So I have my treatment session I'm going to take maybe 5 minutes of that session with the breather, and that leaves me plenty of time for other direct methods like NMES or other traditional exercises. There's more evidence about this in the science, and you can find this again, like Nina mentioned, on the science blog of our website.
Now, our next question comes from people on oxygen. So Dr. Berlin, somebody that's on oxygen, whether it's as needed, PRN, or continuous, would they use RMT? Would that be something that we would use with them while they're on the oxygen?
Yes, absolutely. Now, obviously, if they're on high levels of oxygen or high FiO2s due to acute illness, RMT may be better served being put off until they recover a bit. But if they are on relatively low flows of oxygen, you can absolutely do respiratory muscle training with that, particularly if they're just on a nasal cannula. So there should be no contraindication there.
Great. We do get that
Actually,
question a lot.
I would go a little further, Tom. I would say that the mere fact that somebody needs oxygen on a chronic basis makes it that very, very likely there's somebody that would be benefiting from respiratory muscle training.
Great. I'm happy to pass that one on. It does come through quite a bit. Now, some people use superficial breathing. And Brenda, I know nurses are noticing that. They are looking for ways to help patients with that. Can you tell us about superficial breathing and the patients you've worked with?
So many times that superficial or shallow breathing, we all use without really recognizing we're doing it. Not until the doctor or an activity, we take a deep breath, and then we're like, I guess I really don't do that very often. We really don't take that deep diaphragmatic breath that often, unless we're walking up the hill from the mailbox, we're going up the stairs, we're chasing a grandchild, and all of a sudden we're realizing, man, I have not been using my full capacity. So really retraining your body to take those deep diaphragmatic breaths can be done by using the breather. It's also a positive way to really relax. It reduces tension. It aids with back and neck pain. I know sometime in the last month I was on the website and I was watching one of Betsy's videos and reading through it, and it was how to relax in stressful conditions. Take those slow, deep breaths in and out, full deep breaths. It really does. You know, as little kids, our parents told us, count to 10 when we're mad. It's the same method. Take slow, deep, diaphragmatic, big breaths.
I think I'm going to jump in. I think what Brenda's talking about is you can use the breather for this. So say you use the breather for respiratory muscle training and your settings are up at 4 for inhale and 3 for exhale. I bring it up because that's what mine's set at. If I'm having anxiety with dyspnea, I can bump it all the way down to 1 and use it as a way to get those nice, slow, deep breaths. Respiration is one thing that we can control that is also a part of our autonomic nervous system. We don't need to get into that too deep here, but we can absolutely take our body out of a heightened maybe fight or flight response in a situation where we don't need to act. We don't need fight or flight. We can use our respiration to bring back that rest and digest of the parasympathetic nervous system.
And if I could add to that, guys, these are wonderful responses. Within the breather training videos, we talk about doing diaphragmatic breathing while doing respiratory muscle training. And I recall many moons ago, the inventor of the breather, Peggy Nicholson, taught me the benefit of diaphragmatic breathing in her pulmonary rehabilitation class back in the early 1980s. So it is an opportunity when you're working with your patient to work on doing that belly breathing, using the diaphragm for those deep inspirations while they're breathing through the RMT device.
Absolutely.
Yeah, I think we're looking at the diaphragm and the respiratory muscles from a very clinical perspective, and we often kind of forget to mention that the breathing, how tightly breathing and emotions are linked as well. And by controlling the breathing, we can control the emotions as well. And it's a very quick and a very effective way. I think we've got the situational breathing strategies up on our website as well now, don't we? And these are really short. You can do them with the breather, you can do them without the breather. Really short. Take 5 breaths in a certain breath pattern, for example, 4 inhale, 6 exhale, 2 pause, just to kind of quickly calm down, de-stress. And it really shows you how quickly by controlling your breathing, you can control and change your emotional status.
Absolutely. One more quick thing I'm going to get in there. As a clinician, we have to look for the diaphragmatic breathing. If we apply RMT to a breathing pattern disorder, we are reinforcing it. So if I have a patient who has this chronic mild hyperventilation and I apply RMT to that, that's not getting the greatest benefit. We have to get to diaphragmatic breathing. I need RMT to be done with diaphragmatic breathing. And if that takes a few minutes of training for diaphragmatic breathing before we jump into RMT, those few minutes are well worth it.
Great.
And if I could add to that, we have videos of just how to teach diaphragmatic breathing, or if you're a breather user, how to do it. Does not take long. It's very important, and it's available again on our website. So we welcome you to take a look at those and reach out to us if you have any questions about that.
There is a difference between inappropriate rapid shallow breathing or one that is truly dictated by a ongoing pathophysiology. So if somebody is having legitimate acute pain, he's going to be doing rapid shallow breathing, and there's no way they can control that.
Okay.
Or if somebody has an acute cardiopulmonary event and their oxygen level is dropping, they have an intrinsic response, completely involuntary and completely appropriate response to breathe that way. It is not necessarily efficient, but it's not something that can control. And that is different from the rapid shallow breathing that is a reflection of anxiety or cognitive dysfunction, fear, basically emotional upheaval, and that is actually interfering with your ability to do what you should be doing, which is diaphragmatic breathing. And that is amenable to intervention. That is amenable to correction by simply increasing the awareness. And that's something that actually, that, as it was alluded to earlier, using the respiratory muscle trainer can help the individual to get more, as I referred to, grounded about that. So they have a tool to kind of rediscover now, where is it that I should be at right now, and then recover, And that is particularly important for the patients who has chronic lung disease, because patients who have COPD, for example, if they experience a anxiety, and sometimes for valid reasons, their ability to recognize that different response in respiratory pattern, intervene and regain their posture, if you will, their rhythm, if you will, their ability to use the diaphragm more efficiently, the faster they recover, the less dyspnea they have. So it's important to recognize where's it coming from, the rapid shock.
I'll just say really quickly, I had a patient with COPD, and every time I'd come in, he'd talk to me like he was obviously end stage and far, but I wish I knew then what I know now about teaching the diaphragmatic breathing and slowing.
In that situation, person-lip breathing or the expiratory pressure is critical, because that's what reduces that residual volume in the lungs to help them increase their FRC and be able to take a comfortable breath.
Thank you.
Dr. Alderondo has to run. He's going to go see a few of those wonderful patients that we've been talking about today and help them. So thank you for joining us. And you go see them, and we're going to continue on with a few more FAQs.
Thank you, Wendy, and thank you, everybody. It's been fantastic joining you.
Thank you.
Bye, Doctor.
Bye-bye. Bye.
Dr. Bausek, back to you. How is the training algorithm designed or developed with the use of the breather? That is a question that we get all the time, and I personally would like to know the answer.
Yeah, that is a really good question. Originally, the training protocol for the breather has been determined by therapists who applied the breather. So when Peggy Nicholson developed the breather, she actually empirically looked for the best protocol. And that's kind of still the protocol that came out. The standard protocol is the 2 sets of 10 breaths twice a day. And this has been applied for 40 years now with consistent results based on patient feedback. So we know that it works, and this is why this still works as the standard protocol. This empirically derived protocol is also backed by a lot of scientific evidence by now that uses this approach, or very similar approaches. For example, the study that we published recently that I talked about, where we used the breather in patients with dysphagia following stroke, they had a protocol of 5 minutes of RMT twice a day. So that's kind of very similar duration. And that was very, very effective as well. The kind of physiological basis of the protocol is that the normal way strength training works, where you have to do about 8 to 10 reps, which is the most effective protocol for any muscle. So that's kind of where the sets of 10 comes from, because if you do, that's an interval training, you do 8 to 10 reps at a fairly high intensity, and then you repeat those sets. So for the breather fit, we do recommend a slightly higher intensity, and we recommend adding a 3rd set. So you do kind of 3 sets of 10 twice a day. This is the standard protocol. However, there are some diagnoses where I would kind of go away a little bit from this strength protocol and go more into an endurance protocol. For example, for heart failure, it has been shown that it's better to work on the endurance. So you would choose a lower intensity and then have more sets or have longer sessions.
Thank you. Now, I love little gadgets, Betsy, and I think it's great to have a manometer, but in my experience and in my gym, we didn't order those. And so now it's new to me, and I really think they're great. But what if you don't have a manometer to be able to gauge the MIP and MEP? What do you do in that case?
There's a couple ways to answer that question, and so I'm going to answer both. For one, when we're assessing, there are many different assessment tools we can look at to find that respiratory muscle weakness. And we go into this a bit more in the clinician training online. But we also need our patients to be training at a therapeutic level. Like Nina said, if we're targeting strength training, we need a good moderate level of effort from them. If we're doing endurance training, it's a little bit less. And without a manometer to use in line with the breather, one thing we needed was a tool to help gauge that effort. And this is the reason we developed the breather effort scale in 2020. We decided to go with a 10-point visual analog scale. A lot of people are familiar with this. They rate their pain that way when they're at the hospital or with the doctor. And then we paired the talk test with it. And the talk test is something you can Google. And this helps clinicians, number one, to train users on how much effort they're using. But also sometimes you're working with a patient that cannot reliably rate their effort. Say they're a child or there's a cognitive impairment. And then as a clinician, I can gauge using the talk test. I can't do it while you're doing RMT because we can't talk and use the breather at the same time. But immediately after a set, I can ask you a couple questions and gauge your effort, your breathlessness. So that tool, that breather effort scale, was developed specifically for this purpose and is available on our website. And I'll give an example also for how the progression of treatment might go. So maybe I have a client, and when I initiate RMT, we find their baseline for resistance, and their inhale is set at 2 and exhale is at 1. After about a week, it becomes clear that they're not training what we call in the zone anymore. And that's good. That means they got stronger. Now we need to increase resistance to get them back to that therapeutic level for the strength training that we're targeting. And that's where the breather effort scale can come in. I would say if you're a clinician, once you start practicing this, it becomes intrinsic pretty readily. But I'll also mention that you can get accessory kits to use a manometer with a breather device. That is an option if it's something that's possible in your setting, and if it's something that's preferred, that is absolutely a way you can go.
Now, next, a lot of speech language pathologists like yourself, Betsy, they're asking about using RMT, using the breather with people with voice impairments. So can you give us a little bit on that next?
Sure. Just like dysphagia, I'm going to say the answer is going to depend on the specific presentation of the voice dysfunction. But here's a general principle of when I would expect RMT to be worth consideration. As I mentioned before, we know that respiration is the power for phonation. And if that power is insufficient for the demand, we can hear it. So I can hear a person increasing laryngeal tension to compensate for a decrease in power. I can hear them speaking on residual air. Sometimes I have clients complain that they lose their voice at the end of each day, or they cannot produce enough vocal intensity to say be intelligible to speak on the phone, or in a busy environment, they couldn't go out to eat and speak with the person they're with. But we also know that continued vocal abuse, say trying to overcome that inadequate power that comes from respiration, that continued vocal abuse can result in pathology, such as nodules. So there are some diagnoses where we can predict. So I know, for example, Parkinson's, I can expect a particular vocal presentation, and I've had great outcomes using RMT with Parkinson's, essential tremor, CVA where I expect a weakness, other diagnoses where there's a neuromuscular etiology impacting voicing. But I will say in cases where the underlying cause is not clear, I absolutely want the ENT, or maybe it's more appropriate the neurology consult to identify that underlying etiology. And then we can decide from there if strengthening the muscles of respiration to improve power for voicing is indicated.
Now, my last two FAQs are going to go to Dr. Berlin, but anybody else chime in if you have something to share. The first one is on use of the breather or use of RMT with someone with a trach and maybe a passing ear valve user.
Yes, you can definitely use the breather in a patient with a tracheostomy tube. Now, ideally, it's a patient that either has a cuffless tube or the cuff is deflated, and then you cap the trach or occlude it with your finger and have the patient breathe through the mouth. That is the best way to do it, in my opinion. Conversely, if that patient does have a cuffed tracheostomy tube, the cuff would need to be inflated, and you can connect the breather directly to that 15 millimeter adapter with the little adapter that comes with in the package with the breather. You can even use supplemental oxygen with a nipple adapter that you would have to get elsewhere if you need to provide that in line with the breather through the trach. But you definitely can provide this through a tracheostomy tube. With a passing mirror valve, I'm sure Betsy has lots of experience with that. I have never used the breather in conjunction directly with passing mirror, but that doesn't mean the patient wouldn't benefit from passing mirror while they're not receiving the RMT therapy. I just have not put that directly in line with the breather, since the passing mirror is a one-way valve and you could only do the inspiratory training part.
Yes, generally if the person is not on a vent, we're working toward passing mirror valve and capping. I generally have the passing mirror valve off because I want both inspiratory and expiratory muscle strength training to happen. But it is possible, and then the person would inhale through the valve and only do the expository muscle training through the breather. So if there's a reason that that's necessary, it is possible.
Yep, you're exactly right. And as I mentioned earlier, even if the patient is on a mechanical ventilator, if they are in stable settings, relatively low chronic ventilator settings, and are stable enough to come off the ventilator with supplemental oxygen for a period of time to do the respiratory muscle training via the tracheostomy tube, they certainly can do that. Obviously, it requires astute patient monitoring, but it can be done.
Very good to know. Now, I hear many clinicians asking about implementing RMT with someone on droplet precautions or whatever precautions, however they word it, where they work. Dr. Berlin, can you take that one too?
Yes, well, it's a timely question given the fact that we're still in the midst of this COVID-19 pandemic here in the United States. But respiratory muscle training is an aerosol generating procedure. And with the SARS-CoV-2 virus, obviously it is airborne and communicable via droplet or airborne particles. And so anyone that has been confirmed COVID positive or is a suspect for a person under investigation for COVID, the clinician should take all appropriate precautions in terms of using appropriate PPE that does filter out particles to that extent, as well as a face shield to keep any particles out of your eyes. And of course, gown and gloves and everything else associated with that. And I will add that respiratory muscle training would not be considered an acute therapy for the management of COVID or other patients with infectious respiratory illness. So you may want to wait until after the patient is over that acute phase to reduce the risk of transmission.
I agree. And then also, if you're able to, I know some clinicians have asked different questions and they've actually given me feedback on using telehealth and using those barrier evals and barrier treatments in order to provide that if they're not allowed to be in the same room because of the aerosoling. So clinicians are smart. They've found some good ways around making sure the patients get what they need once they're out of that acute phase, like you said.
Mm-hmm.
Well, this has been very informative. I think our viewers are really going to learn a lot and be able to answer some of those frequently asked questions and get the information out there. I am very impressed with this expert panel, and I appreciate each of you taking time out to do this with us today. Now, as a viewer, make sure you do, we've mentioned it several times, make sure you do check out our website, pnmedical.com, because there are so many additional webinars. There's so much information and resources. We really are dedicated to the education, so make sure you check that out. And thank you for joining today. And from all of us at PN Medical, good night.